Today we have an interesting case in Bangkok, Thailand. Only one case. We had a 16 years old guy. He was stabbed multiple times and assaulted 15 minutes prior to admission to the first hospital. And obvious injuries that we can see, we could see 3 stab wounds on the left thoracoabdomen on the back of the patient with active bleeding. At the first hospital, it was a nearby private hospital. Airway was patent. He was quite alert initially. And he had decreased breath sound on the left lung, and he was breathing fast. On circulation, initially his blood pressure was okay. He was tachycardic, and he had active bleeding from the stab wound at the back. After a while, he became drowsy, and he could still move all his extremities with a good pupillary reflex. And exposure, as you can see, he had 3 stab wounds on the left back thoracoabdominal region with active bleeding. And he had some deep cut wounds on both of his hands, deep to tendon. So first question to the group is, what should be the initial management for this patient? Gary, could you please moderate for me?
Yes, sir. Let's go to Philadelphia. Dr. Alex, your comments, please.
So it looks like the airway is intact. Breathing, you have diminished breath sounds on the left side. So I think a chest tube would be a good idea to place right now and see what comes out of the chest tube. He may be hypotensive from tension pneumothorax, but also from bleeding. He's tachycardic. His initial blood pressure was okay, but he's probably going into a class 3 to 4 hemorrhagic shock as he's being evaluated. The lower stab wound could have certainly penetrated and got into the abdominal cavity, maybe even retroperitoneum, kidney, or even aorta. I would be curious to see if he has equal femoral pulses. If there is a difference that could be, assessed during exam. I would certainly, if his GCS worsens, I would certainly intubate him because he will need to go to the operating room. But I would do the chest tube. I would make sure I start MTP. The laceration on the extremity. If it's actively bleeding, I would control that with a tourniquet or just a good pressure gauze, and then also do a fast to see if there's any free fluid in the abdomen. And I'll try pericardial view, but if you have diminished breath sounds on the left and you have a hemopneumothorax, it may not be a very good yield, especially if it's negative and you have something going on in the left chest. It may be decompressing in the left chest if there is an injury to the heart. Well, those would be the initial things I would do, and I would watch that patient closely and prepare for operating room. Thank you.
Thank you, Dr. Alex. Let's go to the UK. Dr. Villaquery. You're muted, sir. Check your mute button, please. Okay, go ahead, please.
Oh, I agree with the first one. I'm the first doctor in the sense that we would probably put the chest drain and assess them with a FAST. The FAST is going to give us abdominal and cardiac signs of what's going on, and stabilize him, with all the protocol that we have here. Some of these patients immediately, because of our rooms, will get a CT scan immediately through it. So that would be one of our things that we would already have some scanning done. But most of them would first receive their chest drain and the FAST, and then they would go to CT scan if that would be it. Thank you.
Thank you, sir. Dr. Hakim, your comments, please. Go ahead, Dr. Hakeem.
Yeah. Thanks, Eric. Actually, the patient appears to be has a patent error, like the previous commentator said, but definitely a chest tube would help, and we'll do a fast quickly to ascertain whether there's any cavity bleed, and definitely activation of MTP and suspicion of abdominal injury plus diaphragmatic injury in this patient. Thank you.
Thank you, sir. Boston, Dr. Hoyman, your comments, please.
We follow the ABCs. So you have a patient who was stabbed, is hypotensive. The first thing I will do is stop the external bleeding if he has anything from the hand. And at the same time, I will probably, because it's really fast, I will obtain a chest X-ray to see what I have in the chest. He might have an pneumothorax, he might have a hemothorax, he might have nothing. The only thing I will do with the fast really will be to look at the pericardial window, because one of the wounds there is anterior and can involve the heart. And after that, I will keep a controlled hypotension, and depending on those things is what I'm going to do. If he has a hemothorax, I'm going to put a chest tube and go to the OR or go straight to the operating room. If he doesn't have a hemothorax or a pneumothorax, I will suspect the bleeding is in the abdomen. I will go straight to the operating room again, keeping a controlled hypotension. I will resuscitate this patient to systolic blood pressure of around 90, but nothing else, and go from there. At this time, we don't have enough information to make a decision yet. Thank you.
Thank you, Dr. Hoyman. Campaignist, Dr. Fraga, your comments, sir.
I agree with previous comments. To put the chest tube, I think is important, but I will order a chest X-ray at the emergency department. But I think this patient needs to put a chest drain, a chest tube on the left. The EFAST exam is very important to look in the pericardium, try to find fluid, blood in the cavity. And if the patient maintain this pressure, I think it should go to the CT before go to OR, if possible, order blood, prepare blood to start the blood transfusion, because he's on Choque, grade 2, maybe grade 3, but have a CT before to plan if it's necessary the surgical treatments. Thank you.
Thank you, Dr. Fraga. And back in the States now is Dr. Untrack. Your comments, please.
Yes, well, I agree with all of those comments. And in this case, the airway breathing circulation, based on the decreased breath sounds, I think even before doing any tests, I would favor an immediate chest tube on the left side. And I'm a big fan of the EFAST. If there were any question, most of the places where I work, it's easier to do to look at the chest wall with the ultrasound before you can even get a digital chest X-ray. So I think the chest tube, then 2 intravenous catheters, and I'm concerned. So at least one of those 3 stab wounds penetrated the chest wall, and if it was either of the 2 medial ones in the direct line, is the thoracic or thoracoabdominal aorta. So once the chest tube goes in, if the patient is stable, then I would favor doing a CT of the chest and abdomen with contrast to see if the aorta is injured. And if it is, then in the operating room, I would position the patient for a left thoracoabdominal incision to be able to deal with the aorta and also the abdomen. And then I guess Dr. Suppa has access to a hybrid room. This might be one of those cases where if it is an isolated aortic injury, then they can deal with it with a stent. There was a case maybe a month ago where they could have just gone right to, they eventually used a stent and they could go immediately to a stent. But anyway, I think if the patient's stable enough, I think a thoracoabdominal CT would be of benefit before heading to the operating room.
Thank you, sir. Let's go to Dr. Moscoso in Peru. Your comments, please.
Yeah, if the patient is stable, I will begin with X-ray, chest X-ray, and EFAST. Depending on what is the findings, I will proceed. It will take some time for us to take to the CT, so we will begin with that.
Thank you very much, sir. Did everyone have an opportunity to comment that wishes to comment before we return to Dr. Suppa? Okay, back to you, Dr. Suppa.
Thank you for all the comments. So what happened at the first hospital? The patient became more drowsy, so they intubated the patient. They put the chest tube on the left chest, and they got like 400 cc of blood. And they did some X-ray, including chest X-ray. They gave the patient fluid and blood and FFP, and they did some suturing on the back and the hand. And they put in the Foley catheter, and they got hematuria. They did fast examination, which was negative, and they spent like several hours trying to treat this patient in the first hospital before decided to transfer to our hospital. And these were the first two chest X-rays of the patient. The left one was before chest tube insertion, and the right one was after intubation and chest tube insertion. We could see like haziness on the left lower chest and some subcutaneous emphysema after chest tube insertion. And they even had time to perform CAT scan in this patient. They did CT of the chest and the abdomen, and they found like a bleeding in the left chest, no great vessel injury from the chest X-ray, some hemothorax and lung injury on the left chest. And on the abdomen, they found just laceration of left kidney, grade 5 injury of the left kidney with a retroperitoneal hematoma. The first laboratory result was hematocrit 50. I think this was after some transfusion, and he had severe acidosis with a bed excess of -21. It took 3 hours before the patient could be transferred to our hospital, which is a university hospital in Bangkok. And unfortunately, 3 hours later, when he got to the emergency room, airway, he was intubated and the tube looks okay. Breathing, he had a chest tube on the left chest, but still had decreased breath style on the left lung. And we could not measure his blood pressure when he first arrived, and we couldn't palpate any pulse. Output from the left chest was around a liter at that time, and he was obtunded at that point. No response, not moving, and the stab wound was sutured already. No bleeding from the wound now. But the problem was that we had no pulse, and we could not get the BP in this patient. And the nurse that came with the patient said that this just happened. In the ambulance, he was more alert, and they could get some vital signs. So we had a traumatic arrest patient 3 hours after stab wound at the left back. My second question was what should we do for this patient?
Go to Campinas, Dr. Fraga.
Okay, so now after 3 hours, the patient is unstable and he is at a trauma center where Dr. Suppa, he has all research to treat this patient. Is this patient at the hybrid room or not yet? Is the hybrid room available?
You mean IR, right?
Yes.
Or hybrid? We have hybrid room available all the time, but we may need some time to get it ready.
Okay, yeah, you have 1 liter on the chest on the left. So it's a surgical patient. I think you need to go to the OR. The previous CT is no diaphragmatic injury. Maybe you can have a hole in the diaphragm. Blood is coming from the retroperitoneal to the chest cavity because there is only a pulmonary injury, but it's a lot of blood, 1 liter. The problem is what kind of approach do at the operative room. There is no blush of contrast in the CT. I cannot see the arterial blush. No arterial blush?
No blush, no extravasation.
No extravasation. And no extravasation on the chest. And how about the diaphragm? The radiologist cannot see the diaphragmatic injury in this CT because
there's suspected diaphragmatic injury on the left by radiologist.
No diaphragm injury or probably diaphragm injury?
Probably diaphragmatic injury.
Okay. I think the blood is coming from the abdomen to the chest. Because you have 1 liter. Probably I'll start with no blood in the cavity. You cannot see blood in the cavity. It's a difficult decision because the patient is unstable. Probably the patient is unstable. Perform a left thoracotomy to approach the lung. But I think if you give blood to the patient, if the patient recover, you can have some minutes to have a decision about which cavity start the treatment of this patient. Because you have the other options. You have a thoracoscopy, you can do laparotomy if you think the blood is coming from the abdomen. It's a difficult decision which cavity start the treatment, but the patient is unstable. So probably you open the chest on the left. If there's abdominal injury, you go to laparotomy because you don't have so many time to take this decision. Okay, thank you.
Thank you, Dr. Fraga. Let's go to, there he is. Dr. Hakim, your comments, please.
Yes, Gary. So if this patient is being given blood and the blood pressure does not rise, either if there's a facility of a Ribova insertion or an ED thoracotomy with cross-clamping of the aorta, and shift the patient to the OR. Thank you.
Thank you, sir. Sarasota, Florida. Dr. Untrack, your comments, please.
Yes, I agree with what Dr. Hakim just said. And Dr. Suppa, you described this as a traumatic cardiac arrest, and the issue is when did it occur? Because it seems like the patient rolled into your emergency room, arrived there, if I understand correctly, in traumatic cardiac arrest, and how long, what did the people transferring the patient say when that occurred? So that's an issue. The other thing is, and I've seen this in small or even large hospitals in developing countries that aren't trained in ATLS, you know, I don't think you would have spent 3 hours suturing wounds and you'd put a dressing, and, you know, that's really distracting. You know, people get distracted by what's obvious, and that's a classical error that we used to do in the States back in the 70s before ATLS. So, and I think that really lost a lot of time. But if this is a traumatic cardiac arrest, you don't know when it happened, but 16 years old, I guess you would assume it happened just as the patient was coming through your door. And as Dr. Hakim said, it's either Reboa or a left anterolateral thoracotomy, get control of the aorta. and the bleeding is either coming from that lacerated kidney or an undiagnosed injury to the descending aorta. And I think that's the source, one of those two, the blood loss from either of those. But I think the first priority is, as Dr. Hakim said, get control of the aorta and then proceed to the operating room.
Thank you, Dr. Ontrak. Let's go to Peru, to Dr. Moscoso.
If the patient is in that situation, I will take it to the operating room. It's probably to have to take a view on the thorax and abdomen.
Thank you, sir. Boston, Dr. Oyman, your comments, please.
Well, this patient, according to the nurse, just lost vitals before he got in. The patient has no pulse, but has signs of life because the pupils are reactive. So probably just happened. And most likely cause this is exsanguination, but the question is where. So if I would know the CT, which we get sometimes, the CT scan transferred to us before the fact, I would assume that the bleeding is in the retroperitoneum. And the retroperitoneum, it could be the kidney or it could be lumbar veins or arteries. So that would be the main suspect. So where do you go? This is what we will, this is, we have one of my partners is in one of the committees that is comparing ER thoracotomy or resuscitated thoracotomy with Riboa. And this, when we were making the final recommendations, led to very heated discussion. Riboa or resuscitated thoracotomy for bleeding inside the abdomen. I have to say that we, I mean, my partner and I, we were in the minority camp. We will do, and we have done it, and probably because of my age, I've done more than the young surgeons, resuscitated thoracotomy for intra-abdominal bleeding. The indication is that you try to increase perfusion to the brain and the coronaries. So you open the chest very quickly in the AD. It takes literally less than a minute to do a resuscitated thoracotomy and cross-clamp the aorta and see what happened. Maybe the bleeding is in the chest. Maybe we're all assuming that the bleeding was coming from the abdomen, but it's coming from the chest. I have a strong suspicion that's coming from the abdomen. I have a strong suspicion that it's a big diaphragmatic injury because the chest X-ray after the chest tube was inserted appears to show some stomach or colon inside the chest. However, if the bleeding is not caused by an injury in the chest, I will resuscitate the patient very aggressively. I will do open cardiac massage, which in an empty heart is pretty ineffective. So the patient has to be resuscitated very aggressively. And after that, I would take this patient to the operating room. How would I approach this in the operating room? I would do a median laparotomy, and after that, do like a Mattox maneuver, a medial rotation of the colon and the spleen to get to the kidney. The kidney will be in the bucket now. There is no question. The kidney comes out. And after that, see if there is any other source of
No. All right, let me take care of it. Okay, please continue.
Yeah, I will take care of any bleeding in the abdomen and go from there. That's based on the limited information that we have. I have to say that what Dr. Ontrak was commenting in developing countries, I experienced that unfortunately in the States when I lived for 2 years in North Carolina, and we were getting patients transferred from far away, 2 or 3 hours away. And I have seen things like that being done by physicians who have no idea of ATLS. So unfortunately, until very recently, this was happening in the States too. Thank you, that's all.
Thank you, Dr. Clement. Let's go to the UK, to Dr. Villaquirin. Your comments, please.
So I agree with the previous surgeon in the sense that this patient is pulseless. He needs to be resuscitated very aggressively. And immediately, I would probably do the left thoracotomy, lateral thoracotomy, clamp his aorta, and you can assess immediately what's going on, and you can see what the resuscitation if you're filling him up, and you can do your if you have to do cardiac massage at the same time, and then I would probably transfer him to the theater after resuscitating and get him going, and then take him for a laparotomy. I would already know if it's coming from the abdomen or not, and if it's, all this, but at least we would control his bleeding from either part, or from his chest or from his abdomen, if we do the thoracotomy, and we can resuscitate him then. Thank you.
Thank you, sir. Philadelphia, Dr. Alex, your comments, please.
Difficult situation. I agree with, the comments before me. So basically, if you have a patient with signs of life who just are arrested in front of you, or in the ER, I think in this scenario I would go with a resuscitative thoracotomy. I think the reason for that is that would allow to cross clamp the aorta quicker than using a Reboa, because it will probably take time to, you have no pulses, you have to get a 5 French sheet, and then you need to upsize it to a 7. Then you need to put the balloon up. It will probably be, my colleagues are talking about a zone 1 Reboa, but with an obvious injury in the chest, I think I would be hesitant to put a Reboa up there, at least for me. So I would do the resuscitative thoracotomy, even though the chest tube output is 1 liter, it may be clogged. There's definitely enough blood in the left chest, so I would do the left resuscitative thoracotomy, cross clamp the aorta, and then at the same time I would still request that I go to the IR suite, because if the heart restarts and you deal with the chest, it's probably a good idea to do an angiogram for the grade 5 kidney and just take care of any potential findings that would cause a late bleeding. I would also, after I bring the patient back after the thoracotomy, I would also do a fast to see if now the fast is positive, because if it's now positive, then whatever's in the retroperitoneum ruptured in the abdominal cavity, and then I would proceed accordingly in the OR. Thank you.
Thank you, sir. Any other comments before we go back to Dr. Suppa? Okay, back to you, Dr. Suppa. I'm sorry. Go ahead, Dr. Orman, please.
Oh, sorry.
Go ahead, please.
Oh, 2 things. One, I noticed on the CT that the chest tube was placed in the anterior axillary line. And that's something that people get confused. My resident gets confused too, because ATLS say between the mid and the anterior axillary line. Why it has to be so vague, ATLS, I have no idea. However, I have seen chest tube placed in the anterior axillary line that went into the right ventricle. So I always tell my residents that the chest tube should be placed in the mid axillary line. There is no any advantage to place the tube anteriorly, and there are many potential disadvantages, in particular in elderly patients with a big heart that can be on the way. Or if the patient has a tension pneumo or something on the other side and the heart being displaced. A quick comment about the resuscitated thoracotomy, because we were in these discussions and people will argue that no, we need to put Reboa. Reboa, as it was mentioned, takes time. It's not fast, and particularly if the patient is in cardiac arrest. The resuscitated thoracotomy, I am very old. We used to compete among the residents who could do the fastest ED thoracotomy. We used to do ED thoracotomies. The fact that I'm calling ED thoracotomy shows my age, probably, instead of resuscitated thoracotomy. Who could do it faster, and we were timing. And the resuscitated thoracotomy can be done in less than a minute. You need to fill the rib. It's 1 cut to the rib, and after that, the careful cut above the rib, and you are inside the chest. Put the financiator retractor. This thing of taking down the inferior pulmonary ligament is total BS. Fill the aorta, put the clamp in the aorta, and it's done. So this should take less than a minute. It cannot compare in terms of speed to a Reboa, Riboa has indications, no doubt about that. It's extremely useful. It's much less invasive. The question is, does resuscitated thoracotomy works for intra-abdominal bleeding? There are some papers, all papers saying that it might not work so well, but you have a patient who is dying. You cannot kill a patient twice. This patient is essentially dead. So try something that has the best chance to give you return of a spontaneous circulation. Doing CPR, close CPR in this guy will be totally ineffective. And so that's the reason I would recommend this. Having said this, this is a very controversial topic. Thank you. Sorry for talking again. Thank you.
It's okay, Dr. Hoyman. I think it was very much appreciated. Any comments on what Dr. Hoyman said?
Yeah, yes, just one brief comment. For the resuscitative thoracotomy, though, to get control of the aorta, I always need to, and I think that's standard, to cut the peritoneum, the pleura, the parietal pleura to get the clamp around. Otherwise, you can't, to have access. If you can comment on that, sir.
Yes, use the tip of the clamp to go around the aorta. Basically, open the pleura with the tip of the clamp. The pleura is very thin there. So I just fill the aorta blindly, because essentially you cannot see there very well, and use the tip of the clamps to go around the aorta. I know that's been to say that you can ensure the esophagus, wherever. Maybe I've been lucky, or all my friends were lucky. We never had an esophageal injury, and it's much faster.
Thank you, gentlemen. Let's go back to Dr. Suppa.
Thank you for all the comments. So we decided to perform resuscitative thoracotomy, but we still call that emergency room thoracotomy in my hospital. And this is the one, oh no, not the one. My chief resident got to the patient first, and she decided to perform left thoracotomy. And she found empty heart with no pericardial tamponade. She opened the pericardial sac and performed cardiac massage with a clamp placed at descending thoracic aorta. Not a lot of blood in the left chest, around 500 cc, but she could see a hole in the diaphragm with bleeding. And after like 5 minutes of resuscitation and medication, we got a return of spontaneous circulation in this patient. And the CBC, the hematocrit at our hospital was 26, and he got pH of 6.9 and base excess of -24 and lactate of 9. So he was very acidotic. And subsequently, we quickly brought the patient to the operating room, just a regular operating room, not a hybrid one. And with the left chest open and a clamp placed on descending thoracic aorta, we performed exploratory laparotomy. And we found like a large retrograde hemanoma at left zone 2, and no other solid organ or hollow viscous injury seen at that point, and a hole in the diaphragm on the left. I think I should continue because this part is not so interesting. So what we did, like Dr. Hodgman mentioned earlier, we did the quick nephrectomy on the left. We didn't think about trying to preserve this kidney because the patient was too unstable, and we got the first CT, which was quite severe, and you can see like a laceration on the bad laceration on the left kidney. And we repaired the diaphragm, and that's it. We could continue the bleeding. We could control the bleeding, and we got the patient back with a better ABG and vital signs. We could close the left chest, fortunately, and at the abdomen, we didn't have to leave the abdomen open. And after several hours of resuscitation in the ICU, we got the normal ABG in this patient, and he was awake. He put out good urine output, no renal failure in this patient. He stayed in the ICU for 4 days, and he was discharged like 2-3 weeks after the operation. And this was how the patient looked before we discharged him home. Okay. So this is the case. I'd like to hear your final comments on this.
Okay, very good. Dr. Moscoso, your final comments, please.
It's an interesting case. I think in the hospital that I work, we will do the same thing because we don't have even the option to think about embolization. So it will be also a nephrectomy, the final management of this patient. Very interesting case, doctor. Congratulations.
Thank you, Dr. Moscoso. So Philadelphia, Dr. Alex, your final comments, sir.
Great case. Thank you for sharing it with us. In retrospect, you know, with the kidney, so there was no blush. The CT scan probably showed no flow in the kidney. So you had a warm ischemia time of, I don't know, at least 4 hours. So yes, I don't think this kidney would have been salvageable. And with regards to the thoracotomy, yes, the way I learned as a writer to do it is to bluntly spread right on top of the vertebra underneath the aorta and just kind of open that peritoneum and put the clamp there, and it does work well. Thank you.
Thank you, Dr. Alex. Let's go to the UK, Dr. Villaquer, your comments, sir.
Yes, congratulations for having saved this patient from being these terrible injuries. I wanted to ask before if first, did the doctor have any access to REBOR or not? And did it cross his mind? And how many people have access in this group to REBOR? Because we don't have access in the UK to REBOR. REBOR is used only probably in London and has been used very, very infrequently. So that's one of the questions I have for the group. And second of all, I wanted to know if you had any problems with abdominal. Do you leave these patients open in such a prolonged time that they were, do you leave them as routine, you just close them, or do you leave them open, and what's your protocol, if you have any protocol, before the closing comments for this patient? I think that I would have done the same thing. As I said, I would have done the thoracotomy and the same procedures you did at the time. Congratulations. Thank you.
Dr. Villaquer, was that a question to Dr. Suppa?
Yes.
Okay.
At the first hospital, I don't think they have an access to REBOR. It was like a private hospital, but they had thoracic surgeon. I think the thoracic surgeon was the first one who managed this patient. At my hospital, yes, we have access to REBOR and we could deploy it. But like Dr. Hodgman mentioned, it takes time. I think maybe 10 or 15 minutes to get the equipment and to insert the balloon and inflate it. It takes time. We usually use a REBOR in a trauma patient with a pelvic fracture and severe persistent hypotension that we want to take to IR for embolization. So in those cases, REBOR could give us more time, raise the blood pressure, and make the patient stable enough to be transferred to the IR. That was the most commonly used scenario for REBOR in our hospital. But with a patient with traumatic cardiac arrest, no blood pressure like this, we prefer emergency department thoracotomy. And like Dr. Alex mentioned, sometimes we could not rule out cardiac injury or bleeding in the chest before deploying REBOR. So that was a concern when we use the REBOR in a traumatic arrest patient. And the second question, we usually leave the abdomen open if we are not sure about abdominal compartment syndrome, or if the patient was swelling in the bowel. But fortunately, in this patient, after we got the bleeding control, the visceral organ was not so swollen. So we decided to close the abdomen and closely observe the patient in the ICU for abdominal syndrome. But usually in this type of patient, we usually leave the abdomen open for a few days to be safe.
Does that satisfy your question, Dr. Record?
Yes, thank you very much. Thank you.
Yes, sir. Dr. Hakim, your final comments, please.
Thank you. Dr. Suppa, congratulations for saving that life. And I just have 3 comments. I mean, just a refresher. When we had the patient, when you examined the patient and found there were less, the breath sounds was diminished on the left side. In a thoracoabdominal stab wound, we should at least keep in mind that probably the diaphragm rupture has caused herniation, which might be another cause of decreased breath sounds on that side. So the chest tube insertion should be a bit more careful as compared to when we do it could be just air or blood. The first point. The second point regarding the ribova, as our friends discussed about the ribo, that it might take a bit longer. I do agree with that, but if you have a case of traumatic arrest where the CPR is ongoing and you have ultrasound facility, probably inserting a ribova would be a bit advantageous, though it might be a bit, it might take a bit longer. But if we use ultrasound, we might capture the vessel early, and it will not interfere with the ongoing CPR. Although, if personally speaking, I would rather open the chest rather than inserting a ribova. The third point regarding the financiator retractor, which we insert, just again a refresher that we should never forget to put the handle on the bed, because many times we see that the hand is on the sternal side rather than on the bedside. And if you have to go for a clamshell thoracotomy, then it becomes a bit problematic. Thank you very much.
Thank you, Dr. Hakim. Boston, Dr. Hoyman, your final comments, sir?
First, I would like to congratulate Dr. Good for a terrific save. This patient in many places would have been dead. And his team, I imagine that your chief resident was very happy after what she did. Congratulations. This was a really, really great save, Dr. Suppa. I don't have too much to add, except that I think that speed is at essence in cases like this. So whatever is faster is probably what should be done. This patient is in cardiac arrest. The cardiac arrest just happened. You have just 1 or 2 minutes to reverse the situation. So at the same time that you are given volume, you need to restore a spontaneous circulation. So the most effective way is, in my opinion, to do the resuscitated thoracotomy followed by the laparotomy. I don't think this patient can go to any hybrid room or any embolization. I don't think there is time, because those cases, reboa or embolization, takes time. They take time. They are great in the specific circumstances, but in this case, you don't have the time. In my opinion, you have to do exactly what Dr. Suppa did, and the picture at the end was great. Congratulations. Thank you.
Thank you very much, Dr. Hoyman. Let's go to Sarasota, Dr. Untrack.
Yes, and I would just ditto what Dr. Hoyman just said, that this patient needed internal cardiac massage. And I think the take-home lesson is that a traumatic cardiac arrest is thoracotomy, the anterolateral thoracotomy, get control of the aorta, open the pericardium. That, I think that's the take-home lesson, that the reboa, which is something I've never done, but it seems like this is not the situation for that. Cardiac arrest, traumatic arrest, thoracotomy. And the other point, a great save, and I don't want to be critical of the original hospital, because they did the best they could. The patient's alive. They got the patient transferred to you, and I would think that in follow-up, a bit of encouragement and maybe a grand rounds about management of trauma, from your hospital to theirs would be would be very helpful to encourage them and help them with future cases. But very, very well done.
Thank you, Dr. Andrade. Let's go to Campinas, Dr. Fraga, for your final comments, please.
Congratulations, Dr. Suppa, excellent case. The treatment was very, very well. And about the question about Riboa, I don't have Riboa available in my hospital. I think in Brazil, any hospital has Riboa. In the public system, any hospital has the Riboa available at this moment. We hope have in the future. Thank you for this excellent case.
Thank you very much, Dr. Fraga. Any final questions before I turn it over to...
There was a question in the chat about the no bleeding on the CT scan. It all depends on the timing and if it's a venous or an arterial bleed. If for some venous bleed, I had to have a delay of 5 minutes. So we do the CT scan and we are concerned about delay bleed, which would be sometimes even in the spleen. We do the CT scan, repeat CT scan around 5 minutes later, and that's where the extravasation is clearly seen, the blush. So I think that's the explanation why it was not seen in the initial CT scan that was done at the other hospital. Thank you.
Thank you for answering that question, Dr. Hoyman. And that was from Dr. Grossi. I hope, Dr. Grossi, that satisfies your question there that you put in the chat. Anything else before we turn it over to Dr. Martos? Okay, Dr. Martos.
Hello, everybody. Thank you, Super, for a great presentation as usual. And this show like difficult management that you did very well at your institution and generate a lot of discussion, a lot of comments. I'd like to use the opportunity of this forum today to say happy birthday to Dr. Gustavo Fraga. So Fraga, congratulations, happy birthday. I wish you another year of healthy, happiness, success, and to you in your life and to your family. It's very nice to have you as a friend, as a part of this group. Okay, Fraga?
Thank you so much. Thank you.
Okay, so remember, this is another meeting for the Parliamentary Society. This Wednesday, we're gonna have every Wednesday, the first Wednesday the month, we're gonna have a meeting at 6 p.m. Miami time. We're gonna discuss cases. We're gonna have a brief interview of former president. We invite everybody to join. We're gonna have a very interesting case from Cali, from Dr. Ordonis. And then also, like you guys to contact Valeria to book some interesting case for our institutions for the next few weeks, okay? Thank you all. Good to see you, Dr. Fraga. Good to see you all, and super congratulations again.